Thank you again, Dr. Williams, for agreeing to see me.
You're very welcome. I look forward to the presentation.
Today, we're going to talk a little bit about understanding hospice care. You do know that that's the subject of my capstone project. I've had the opportunity to shadow here quite a bit, and so again, thank you for the opportunity to present this. Where we're going to start with understanding hospice care is just why it's so personal to me. Um, I guess hospice care is ultimately where I see my career ending, or what's the next stage in social work for me is hospice care. Right now, I work as a school social worker. Um, it's very personal to me because a few years ago, um, we lost my dad to prostate cancer, and so we became very intimate with the hospice workers. As he transitioned to, as he went, we prepared him for death. And so just having such an intimate relationship with, his hospice, his team of people, it just became such a passionate, interest for me, and just seeing how it all sort of played out. And that's why I chose hospice care as the subject of my capstone 2 and 3 presentation. So as we get started, the where I would like to start is just talking about some statistics surrounding death. Some of it was very eye-opening to me. While I thought I understood what it meant to sort of get to choose where you die, it was sort of startling to me when I saw that 7 out of 10 Americans want to die at home. And I think that statistic was just very surprising to me because I actually again watched my dad die at home, and it was still so hard to be in the home afterwards. So when I saw that 7 out of 10 Americans prefer to die at home, I thought that was a very interesting place to start talking about understanding what hospice care is. You have the handouts. I won't read every single slide to you, but I will try to highlight a bit from the majority of them. So while we know 7 out of 10 Americans prefer to die at home, 25% actually do die at home, according to the CDC. And then close to 50% of Americans die in a hospital or some type of long-term facility or nursing home. I think about patients that are terminally ill being in a long-term facility. And while I know the staff is great, the staff here, there's a lot of hospice, organizations popping up, and I know the staff here is great. I just think about how we all, as a community, we were able to surround my dad as he faced death. And I just, when I was putting this presentation together, I sort of thought about someone having to die, alone in a long-term care facility or in a nursing home. It doesn't happen a lot, but I mean, it still makes me, it still makes me sad. But that's just some statistics to start off as we talk about hospice care. My objectives for this presentation is to touch a little bit on the history and the background of hospice care, not much, because this is a hospice agency and I don't want to waste time presenting, what I know you already know. Just talking a little bit about what the concept of hospice care is. Some of the medical teams I've been able to sit with here, and just a little bit of the research I've done. And then sort of move into talking about, how hospice care is being paid for at this point, some of the changes that has occurred over the last, 6 to 8 years, just with how payment and reimbursement for hospice care is, and then some of the advantages and disadvantages of entering a terminally ill patient into hospice care, some of the difficulties and problems, and then just an individual, and what end of life care to me should look like, and then just some of what I've actually come across in my research. So that's the objectives. And again, I won't read through every single slide because, again, you have them available, and some of this stuff I know is, common knowledge to you in your everyday work. Um, the thing that I found interesting about, hospice care is, where it started, how recently it started. I think about, my dad was born in 1958, but the concept of hospice care wasn't really introduced until 1965. So I think that this occurred, in the last 50 years. We started to see this transition to caring for are terminally ill and how we prepare the patient and the family for a patient transitioning to death. And in line with the history of hospice care being introduced in 1965, I found it extremely interesting that formal hospice care was authorized by Medicare in 1980. So we're talking relatively recent. I mean, it's not something that's been, decades. I mean, it has been, but it's still 1980 isn't, I have students that were born in 1980. So it's a relatively new concept, and just to see how much it has evolved in just since 1965 to now, it's eye opening. And so just to again touch, I didn't want to go into who started hospice care and where it started, but it's the concept initially was introduced in 1965, and then it's formally authorized by Medicare in 1980. And we'll touch a little bit more on how hospice care is paid for by Medicare and Medicaid and things like that a little bit later in the presentation. And so just to talk a little bit about what hospice care is, and the services that's provided to terminally ill patients that's in the last phase of life. It's certainly medical support. The teams here, I've had the opportunity to sit with the medical teams here as they sort of come up with a plan for how best to make a patient comfortable. And that to me is just very, again, having an intimate relationship with my dad's hospice team, just the amount of care that goes into preparing a patient, with that medical support piece. Especially through their pain management and sort of making a patient that's terminally ill, comfortable. That's a large part of hospice care. And then the two pieces that I find to be the most fascinating about hospice care, and again, focusing on, the quality of life for patients that are terminally ill, will be the spiritual support and then the grief support that's provided, not only for the patient, but for the family. So those were just in the scope of that collaborative effort that I've been able to be a part of here. And just in my research, a lot of the things that I've read, it really talks about the need for, a holistic, collaborative approach to, really focusing on the quality of life for a patient that's, terminally ill. And so to define what the hospice patient is, it's, a patient that has a life expectancy of less than 6 months. And some of those terminally ill diagnoses that, that are common would be cancer, end-stage kidney disease. My dad had end-stage renal disease. He ultimately died of prostate cancer, but, liver failure, strokes, and coma. These are just some of the things that the diseases that families are faced with terminally ill patients that have entered into hospice care. Another thing that I find to be quite interesting, at one point we thought, when we thought of cancer or liver disease or strokes, we thought about an older population, but we're seeing now that it's comprised of all ages, and it is not just limited to the elderly. For me growing up, I'm 39. Cancer was not a young person's disease. And, now we see children that are entering into hospice care that are dying of cancer. We see young adults. It's not just, an older population anymore. And then there's the piece of hospice care that, the patient that no longer wishes to receive prolonged treatments. They've received a diagnosis that would indicate that it's a terminal disease and they don't want to receive any life prolonging treatment. So, again, the part that I found fascinating about the hospice patient is it is not just the elderly, not just, the older generations entering into hospice care. We've got children, young adults, the middle aged adults that are entering, that are in hospice, unfortunately, receiving hospice care. But again, that's just some of the common terminal illnesses that we see: cancer, um, kidney disease, liver failure, and stroke. That's just some of them. Of course, we know there are more, but we know that the hospice patient usually has less than 6 months to live. So, when is hospice care provided? I know here it's a 24-hour schedule, and that's the same as with most agencies that I've actually researched. Again, when a patient has 6 months or less to live, most agencies will function on a 24-hour schedule, and have around the clock nursing. And I know that one of the things in the last meeting, I was able to sit in, we talked a lot about the role of the chaplain and the social worker in the team effort. And so a lot of the chaplains and social workers are on call. I think about that when I thought about, just for me, I know that hospice care is truly, what I'd like to do next. I thought about that. If you get that phone call in the middle of the night, how are you prepared to serve that family as a social worker or as a chaplain? And I can imagine the amount of training that goes into being available for that family. So again, just like this agency, most of them operate, once a patient is entered into hospice care on a 24-hour schedule, and nurses tend to come out every day or every other day to check in with the patient and see how how they're doing. Hospice care is provided, as we know, usually hospice is not a place, it's a service. And so it's generally provided wherever the patient is. Um, I know that for my dad, he stayed in of what would have been a long-term facility until we decided that my mom was okay with him going home. But hospice care most often occurs at home. There are other locations like hospitals, nursing or assisted living facilities, hospice residencies, and again, long-term living facilities. It was difficult for us because it was hard to make that decision, because we knew that my dad was terminally ill and he did not have long to live. He, as a matter of fact, by the time the hospice nurse actually got out to sort of enroll my dad in the program, he died that day. And so, but he spent quite a bit of time in a long-term facility. But by the time we got him home, he died that day. And so one of the challenges that we faced, and what took us so long to actually bring him home, was because the family still had, that's the home I grew up in. We had lived there. My parents had lived there almost 40 years. It's very hard for the family of a patient to then have to still live in that home. But generally, hospice care is provided at home. So, talk a little bit about palliative care versus hospice care. In palliative care, it quite often gets confusing because there is some overlapping. Um, a patient that is in palliative care, they're not necessarily at the end of life. There is still some life prolonging, measurements being taking place, versus hospice care, where we know that it's a terminal illness and the life expectancy is less than 6 months. Palliative care is usually covered by Medicare and most traditional insurance companies. And they've got quite, aggressive treatment still taking place to sort of prolong life. Whereas the opposite side to that would be, once a patient is entered into hospice care, it's really just pain management to allow a patient to transition with dignity. Again, both are covered under Medicare. There's quite a bit of overlapping in just understanding the concepts, but for me, the main difference would be, when a patient is in palliative care, there is still some aggressive measurements being taken to prolong life. And there's no time, I'm going to say, a time limit that has been set, or given. It's just whatever you can do to prolong a patient's life and still treat them for the symptoms that's presented with their illness. Versus hospice care, we know that that patient is terminally ill. They probably won't recover, and at that stage, they're just, being treated for pain management. The overlapping piece is the services that's received from an agency, and the key piece would be that emotional, physical, and spiritual support. I think they, in understanding both concepts, that's important to point out that that's the overlapping. Both the, in both instances, the patient should receive that emotional and spiritual support. As I said at the beginning, hospice, care is truly a collaborative effort. Since I've been here, I've been a part of several team meetings that, starts with the medical team and it goes into, the physician, from volunteers. I'm here in a volunteer capacity, to the social worker, to the home health aides, the people that are going out and truly just doing a wraparound services for a patient, um, and just making not only the patient but the family comfortable. So we know that to be part of a hospice medical team, it is truly a collaborative effort. It's been definitely one team talking to the other so that a true treatment plan is in place for a patient, and that it is something that everybody is comfortable with, especially that patient and the family. The team usually consists of doctors, nurses, again, home health aides, social workers, a chaplain, and then trained volunteers, which is, again, one of the training that I'm going through. Um, One of the things that I chose to focus on while here has been just that emotional and spiritual support. I think the medical team focuses, the key focus is the medical aspect of, hospice treatment, as it should be. It's about managing someone's pain that's terminally ill. But I often feel like sometimes that mental and emotional piece gets a little bit neglected because the social worker is on call, but when you're in a home and you're, let's say, taking a patient, I've seen, taking a patient's vitals and just trying to get them comfortable, it's almost like they're crying out to talk about, one patient we had was wanting to talk about the afterlife and what comes with dying, and I looked at that home health aide that I was shadowing that day. She didn't really know how to address that. She was extremely uncomfortable with addressing, again, his concern was like, I'm dying. What happens to me when I die? And so that to me, as a social worker, is one of the key components of the hospice team, is just really addressing that emotional and spiritual need for not only the patient, um, but the family. It's so hard to watch a loved one transition to death. It's hard to watch a stranger, but when it's someone that you are intimately involved with, or a parent or a loved one, it is just extremely it's emotionally taxing. And so to have that added emotional and spiritual support while you're making a patient as comfortable as possible, to me is just so vital. I'm going to transition a little bit to who pays for hospice care. And I think in recent years, what we've actually seen is that with the Affordable Health Care Act, that's another added bonus to paying for hospice care. At one point, when insurance companies weren't necessarily offering insurance coverage for a patient that was terminally ill. That has definitely changed in the last 6 to 8 years with the advancement of the Affordable Health Care Act. Medicare definitely pays for hospice care. It's paid for under Medicare Part A. The majority of state Medicaid programs will cover hospice services. And then if a patient has private insurance, that will pay for hospice care. One area of concern for me is the self-pay for hospice service. While that is definitely a component of who pays for it, oftentimes when you've been diagnosed with a terminal illness, you're not working. And especially if your income was the only income, that family is already having to face some serious challenges. But then to think you have to use, possibly savings or try to come up with a way to sort of pay for hospice care, to me, that is an area of concern. So that's why I sort of applaud the Affordable Health Care Act, because we know that, again, insurance companies aren't necessarily denying us coverage because we have a terminal illness. Us a little bit about how hospice care is paid for. It's definitely paid for under Medicare and Medicaid. And then we know private insurances will definitely cover hospice services as well. And patients always have the option to pay out of pocket. Just a few of the advantages and disadvantages of hospice care. We know that a pro of it is you are definitely surrounded if hospice care is taking place in the home. You're surrounded by your loved ones in a familiar environment. The family is sort of in on the entire process. And the patient is receiving 24-hour care. That's to me, the advantages of hospice care. But the other side of that, in having lived through it, the cons of hospice care definitely is a patient is sort of deciding to say, I'm going to die at home. And that can be extremely hard for a family. Because again, my mom ultimately moved. My parents had been in their house for 40 years. My dad died at home, and she thought initially she could do it. She could stay in the house. But 6 months after my dad died, she moved. And so that to me is definitely a con or a disadvantage to a patient, sort of dying at home. The family or the loved one that's left to sort of still be in that house or still have to, live with the memory of that person dying at home. Um, and so a little bit about, for me, what the issues um, with hospice care is that when you're in an area where there's not much accessibility to services. I'm in North Carolina. We have some areas that's sparsely populated, and so that accessibility to hospice care is not as readily available, considering if you're paying for someone to come out to the home. You usually pay by the mile and by the visit. And so that's definitely an issue. If you're not in a hugely populated area, services may not be readily available for you. You're still a terminally ill patient should you not have the same access to care. But when you're in a area where it's not much, not populated, then you're limited to the services that you can receive, especially if you're doing it at home. You ultimately may end up not having the option to have hospice care at home. You may end up in a facility. And then another issue, as I said, is just financing it. If you don't have Medicare, Medicaid, or private insurance and you have to actually pay for it out of pocket, it can be financially draining on a family to have to choose between receiving these services and, potentially, ultimately having to pay for a funeral service. It's just a very hard decision to make. And then sometimes hospice care is underused by patients that could really benefit from it. A lot of people, it's very surprising since I've been here. It's very eye-opening to me how many people choose to just not have anything. They really want to die alone. One of the things that I've noticed in going out to a few of the homes is patients, they really don't want their family to see them dying. They really want them to be remembered as how they were, as opposed to what the illness has done to them, or what shape or form it's taken on with respect to their body. And so a lot of people don't want people coming into the home. They really want to die alone. And so to me, that's another issue, is how do we reach that that patient that really wants to die alone and not have the family see them in this condition, or have the family remember them the way they were. And so to me, that's another issue in hospice care, and just trying to reach that patient to let them know the value of having the services offered from hospice care. And then an individual's right to end-of-life care is sort of in line with a person not wanting to, take advantage of be a part of hospice care. a patient's, individual right to end of life care, the basics that, every patient or every person deserves is sort of the same as if you were not dying. You deserve to be treated with dignity and respect from your medical team. And that's the same whether you have a long-term illness or you're terminally ill, or if it's, you fell and broke a bone. Every person deserves to be treated with dignity and respect, and have their privacy and confidentiality respected. And so for me, it's one of those things where we were faced with one of the most difficult decisions in life. When we knew my dad was dying, we thought we could benefit from hospice care to just help us make some very difficult decisions. And so that too is in line with the patient's individual rights to end of life care. It's just some help in making difficult decisions because this is your loved one. And as much as death is a part of life, sometimes it's just hard to make some decisions. And so that's where that collaborative effort comes in. I think it's important to note that hospice treats the role of hospice care is to treat the whole person and not just the disease. I found that to be quite interesting in our situation. Is my dad he stayed in a long-term facility for a while before we decided to bring him home, but he was an angry patient, and it took some very skilled workers to he didn't want to face his own mortality. It took some very skilled workers to treat him as an individual and not treat prostate cancer or end-stage renal disease. It took a very skilled person to say, this is just someone that is facing death, and he's afraid. And so the role of hospice care is to treat that whole person, and that's definitely was my experience and why I became so interested in hospice care, because it wasn't just treating his disease. It wasn't just about the prostate cancer. It was about getting him ready for death and getting us as a family ready for death. So in conclusion, basically, I wanted to touch on what hospice care is, why it's important to me, what hospice care is, and just what a hospice patient looks like. We know that it's someone that has a terminal illness with less than 6 months to live. And that is just a very heavy burden to carry as a patient, as a family. And so hospice care is designed to focus on both, the patient and the family. And that's something that was very important. His hospice care team got us ready as a family from an emotional and a psychological standpoint to know that the end was near, and just really offering us that support for not only my dad as a patient, but for us as a family. And so I think that's why hospice care is so important to me, definitely as a social worker. I know that when that emotional need goes unmet, you can get into a person can get into all types of depression and denial. But I think part of why I fell in love with this field, while I don't necessarily want to spend a lot of time with death, I fell in love with this field because it's such an important resource. And having had taken advantage of it for my family, it's just such a vital resource, and it's something that I think every family can benefit from. So I think this is the end of my presentation, and I thank you for for your time.